Okay, I want to welcome everybody to this particular session under Therapy Ed. Um, my name is Dr. Carolyn Higdon. I'm going to make a couple of announcements and then I'm going to turn it over to Miss Gina Keene, and she's going to review autism tonight and present some questions and answers that are very similar to those on the Praxis on this topic. So one thing I do want to recommend to anybody who's on tonight is the Therapy Ed app is available at the Therapy Ed website. And I would suggest everybody get that. It's pretty affordable, and I think it will give you another whole set of questions and answers on the different topics that we're covering under Therapy Ed. And of course, the Therapy Ed study guide, which has some practice tests at the end of it and is very, very useful. And I'm sure Ms. Keene's going to be referring to it tonight in her presentation. The other thing that we've done is we've started to post the content for each Wednesday night a week in advance. So there is a recorded video of the content in autism at the website. And the expectation is that people review that and then come to the Wednesday night office hours with their questions and practice their Q&A with the faculty member. The faculty member will be reviewing the main points of the presentation, and then we'll start to ask questions and give you some practice in preparing for the test itself. I think, let's see, I think that's probably everything that was on my list. If you do attend the session, and I keep track of who attends, then if you need extra help once the session is over, you can either come to me and I'll put my, after I sign off, I'll put my email address in the chat. You can come to me or you can come to the faculty person who's lecturing, and they will help you with any additional questions and help that you might need. So we're not going to do it for random people who don't attend the lectures, but if you attend the lecture, you get that extra help if you want it or need it. And especially down the road as it gets closer to the time that you're going to take the test, that preparation might be useful. Okay, Miss Keene, I'll turn it over to you. I will silence everything on my end, but I'll be here if there's any problems. I will also monitor the attendance, so when people come on, I'll let them in. You don't have to worry about that.
Okay, thank you.
Okay.
And then do I have the ability to share my screen?
You should. Would you check and make sure? I gave it a little earlier, but maybe.
No, it says disabled.
Okay, here we go. Here we go. Now you should have it.
Yes, thank you.
Okay. And just holler if you need me.
Okay. Well, I want to welcome you to these open office hours on the topic of autism. Again, my name is Gina Keene, and I am a speech therapist with Children's Hospital in Colorado. I'm on their autism team. So that I serve doing interdisciplinary diagnostics and evaluations for autism for an infant toddler clinic and then a preschool and school age clinic, as well as doing interventions. So please take this time to ask any questions that you might have. Feel free to come on and let me, if there's anything that I'm talking about that you have questions about, please feel free to interrupt. Please feel free to get those questions out there, because what I want you to walk away with it from this is having a good foundation, a good understanding of a way to think about autism as you approach taking the Praxis. So I'm going to do some brief background and talk about research and how autism is diagnosed and what are the characteristics before I go through any of the questions. But again, please let me know if this is something, if there are certain areas that you would really like to talk about. So historically, autism was first talked about by Leo Kanner in the 1940s. He observed some children and he noticed certain behaviors. And so when you're thinking about autism and you're thinking about how do we talk about it, how do we recognize it, how do we evaluate it, that idea of behavioral characteristics is going to be very important. there is no test that we have now that looks at a specific way to diagnose autism medically. It is through a behavioral observations. So we need to have an understanding of what those behaviors are. But that doesn't mean that the etiology rather comes from just this set of behaviors, which is one of the things that Leo Kanner and people that came after him were wondering, is this just a psychological response to environment? But we do know now that no, the etiology is a neurobiological biochemical disorder. There is a difference in how the brain is wired. There is a difference in how the brain is experiencing the world. But we don't have a very clear cause. And I know that this is become a very interesting topic as of late. But what we do know is that there seems to be this interaction of genetics, environment, neurochemical, how the neurochemical receptor is being received within the brain and participating in those neural connections in the brain. And because of that, then you begin to see these behaviors. And that is what we can observe now. And that is what we're looking for when we're talking about autism. Overall, you're going to hear me talk a lot about this idea of quality and quantity. And really, when you're looking at these behavioral characteristics for autistic individuals, is that's what you're looking for, a difference in those. You're looking for a difference in quality and quantity. And you're looking for those differences in social reciprocity, in some speech and language development, but we'll talk a little bit about what that means, and then interactions with objects. If you look at the DSM-5, there are two areas that an individual needs to show difficulties with in order to receive a diagnosis of autism. So the first one is social communication differences. You need to see these differences. Again, it's about quality. You need to see differences in social reciprocity. So what is social reciprocity? Well, that's that back and forth of communication, that back and forth in play, the back and forth in having a conversation, the back and forth in requesting, think about all those functions of language, being able to ask questions, being able to expand on topics, difficulty with being able to do that in a relationship. But you also have to see difficulties with nonverbal communication. So this means difficulties with gestures, difficulty with facial expression, difficulty with understanding those in another person, which ties into that social reciprocity. And then you need to see difficulties in maintaining relationships. So in young children, this may be something like really having play by themselves. They have difficulty being able to initiate play with another child. They have difficulty having friendships. They have difficulty reading those friendships, knowing when somebody wants to be a friend, when somebody doesn't want to be a friend. Some of those social cues that might make having that relationship more difficult. In order to have a diagnosis of autism, an individual needs to show difficulties in all three of those areas of social communication. I want you to note that one of the things that's important is that in the social communication piece, there wasn't anything that said they have to have a language delay, that they have to have that was a part of an older paradigm for understanding autism diagnoses. That is not a part of our current understanding of how we diagnose autism. So they have to have difficulties with really that pragmatic part of language is what we're talking about. Now, I say that with a caveat is that you will frequently see language difficulties. You will frequently see a speech and language delay, but it is not necessary for the diagnosis. So you may see you may evaluate a child who has wonderful semantic and syntactic and skills. They're gaining those grammatical components. They're getting those morphological that morphological development is happening. But how are they using that language that maybe they have? So that's the question. So really, the social communication part is that pragmatic part of language that you have to have. You also have to the individual has to show some restricted and repetitive behaviors. A lot of times we refer to these as RRBs. So in addition to having those three difficulties with social communication, they need to show at least two of these four items. So they have to have stereotypical movements. And these can be anything from kind of the conventional, we think of the hand flapping that might go with that, but it could be a kid who turns, or a kid who maybe has a tick, or maybe they're just repetitive movements of running around the room. That could be a stereotypical movement. Another thing to think about is sometimes stereotypical speech can be considered that stereotypical movement. Are they saying those same kind of scripts or gestalts all the time? Sometimes I'll see kids who don't necessarily have those stereotypical movements, but they do have that those gestalt patterns of learning language where they say a script over and over again, and that becomes one of the criteria for stereotypical movements. Another area is insistence on sameness. So there's this rigidity in how they are interacting with the world. So the individual may need to eat only the same kind of foods all the time, or it has to be the same brand. And if anything is different, then there's a problem. The bedtime routine has to be exactly the same. They have to sit in the same chair at a meal. And so there has to be that insistence on that rigidity. Again, that's about that quality. Think about it. They're participating in the daily activities, but there's a difference in how they're able to do that. We had a mom recently just report that her daughter does fine if they follow the routine, but if, let's say, when they pick her up from school, they have to stop by the store, then the rest of their night is thrown off. She has that insistence on sameness. You'll also see maybe highly restricted or fixated interests. So again, some of the things that people think about are the individuals that are really interested in cars or trains, or they know the bus schedule. And there's also this understanding that sometimes they don't really recognize that other people might not be interested in that, but it's their special interest, something that they are willing to be very hyper-focused about and are really interested in it, and they know all about it, and they're maybe not interested in other things. But I want you to think that it can be anything. It can be clocks, it can be vacuums, it can be the stars, it can be anything that they might are very interested in. A lot of times when we're doing evaluations of young kids, we ask, do they play with things that you wouldn't necessarily expect? Are they always having to, we'll have kids like, well, yes, they always have to carry 2 rocks in their hands, or yeah, they're really interested in the kitchen utensils, or they're really interested in bottles, and they play with the bottles and they line up those bottles. Some of those that look different than what other kids might be doing that we might expect, or that we might see in neurotypical development. They also may have hyper or hypo sensory input. So they experience the world in a different way when it comes to sensory input. So they may have, and this can be any of the senses: visual, tactile, auditory, kinesthetic, proprioceptive. How are they experiencing the world? So sometimes you think about these are the individuals who are maybe sensory seeking. So they like the squeezes, they like the hugs, they like the deep pressure. Or sometimes they might be the individuals who are very upset by loud noises, or get overwhelmed when there are too many people, large crowds, bright lights. Those kinds of things can bother them. They may be the kids too who are like putting everything in their mouth because they're seeking some of that proprioceptive information from the world. Tiptoe walkers, those kinds of things. For the diagnostic criteria, an individual only has to meet 2 of these. They have to meet the 3 social communication markers and 2 of the RRBs. If an individual has behaviors that are observable in both of those areas, observable or reported from family a lot of times, then you can move forward with thinking perhaps this is autism. And so any questions about diagnosing autism and what the criteria is for diagnostics? No? Okay. Really quickly, I just want to talk about what I just presented to you in the DSM. This is a medical diagnosis for autism. And this can be, it's typically done by a developmental psychologist or a developmental pediatrician. ASHA does say that SLPs, as long as you have the experience and the knowledge, that you can diagnose autism. And those would be those medical diagnoses. Sometimes that's very important because this helps individuals get supports that they need. They have to have that medical diagnoses for insurances to pay for certain therapies. If families are interested in doing something like applied behavioral analysis or ABA therapy, a lot of times places will not accept them unless they have a medical diagnosis of autism. Medical diagnosis of autism is different than an educational diagnosis of autism. A child can go and get a medical diagnosis of autism, and the school can decide whether or not they would like to give that child that diagnosis on their IEP. They will also do their own evaluation, and because they are looking for how do these behaviors then affect them academically? How are these behaviors that are being noted, are they impacting the child within the classroom? And then they may decide whether or not to give an educational diagnosis. And I hope that that kind of makes sense. But it's really, again, about services. So services in the school and services within more of the community for ABA and therapies. Please stop me if you have questions. Once an individual has received that diagnosis of autism, each of those areas, social communication and the RRBs, will receive a severity level. And while the behaviors are a bit more objective, and you can say, yes, I've seen these behaviors, you've had an in-depth family history and case history where you've found out how this is impacting an individual's daily life, those are a little bit easier. The severity levels are a bit more subjective. Each of those two areas, social communication and RRBs, will have its own severity level. So you could have social communication level 2 and RRBs level 3. So they don't have to be the same. The other thing with the levels is that the levels can be fluid. They can change over time. They can change sometimes in situations. So while the autism diagnosis is a lifelong diagnosis, because this is a neurological difference, that's not going to change, but the severity level may change. So you may have a 2-year-old who's coming to you and they are a level 3 social communication and a level 3 RRBs, and then they receive therapies, they receive interventions, caregivers receive training. And then when they get to school age, maybe they're a level 2 social communication and a level 1 RRB. That's quite possible. Those can change over time. But how do you know the difference? And how, as a team, when you're making this call, do you make the difference? The question you want to be thinking about levels is, how much is this impacting the daily functioning of the individual and those that are caring for that individual, right? So frequently when we're doing evaluations is families will come in and they're like, yeah, I don't really see, it's not really that much of a problem. But as you start to talk to them, you find out that they are working very, very hard to make sure that things stay the same for that child, to make sure that they have the foods that that child will eat, to make sure that all of their clothing is blue, and that they have the same routine all the time. And the family may not even necessarily be recognizing the amount of effort that they're putting in to make sure that that child can remain kind of calm and regulated. So you're starting to think, how much is this impacting? So if an individual is a level 3, it is impacting in a severe way. So a lot of times you'll see those that they have very limited ability for initiations, for communication. There's very minimal response. So these might be the kids who, when you try to engage them in play, they turn and they play with their own things, and they get upset if you play with them, right? They have extreme difficulty with change and transition, and the RRBs are really interfering with their functioning. So RRBs in and of themselves can be just fine. They can be a way to help a child regulate themselves, help themselves feel better, help themselves feel calm, be able to handle an overwhelming situation. But if those RRBs are impacting how that child can do those daily functions in a severe way, then that's more of a level 3. If that rigidity is so much that the family can't do it, can't do anything outside of the routine, or the kid is down to eating 3 foods because of the rigidity. That would be like a level 3. A level 2 is you might be getting some of those responses. Sometimes they're going to interact with you. Sometimes they're not going to, they're going to want to do more of their own preferred activities. They may be inflexible in their behavior, but they, with some support, they're able to handle those changes and handle those transitions. The RRBs are going to be noticeable to other people on a level 2, but they don't necessarily interfere with function. So you could have a kid who is doing the hand flapping, but that is not, people would notice that, but they're able to do that while they're doing some of their activities of daily living. And it's not impacting their ability to do that. And then your level 1 are that there may be some difficulty with initiating. They may be more interested in what their special interests are, or they may have decreased interest in social interaction, but ultimately they are functioning fairly well throughout the day, just with some differences in how that might look in quality. Questions on the levels, they can be a little tricky. And I will tell you, even as our team, when I meet with our team, and the way that we do this with our team, I work with a psychologist, an occupational therapist, and a medical provider, and myself, the speech language pathologist. And we each do our individual testing. We come together and we talk about these, like, how hard was it to engage this child in play? How hard was it to, what kind of sensory what kind of sensory things did somebody see? Was that interfering with our interactions? Was that interfering with how the child was playing or how the child was learning? And we'll try to make a decision as a team, but it can be a little tricky at times to figure out what level it is. But really just think level 3 severe, level 2 marketed, and level 1 just there's more independence in level 1, less level of support. Any questions about these? We'll move on. While you have those levels, I want to just talk a little bit about what are some of the other characteristics that you might see that fit into those diagnostic criteria. So we talked about difficulty with nonverbals. So you might see things like flat affect, or decreased or a different use of eye gaze. Again, we're not really worried so much about eye contact anymore, but is there a difference in how the kid is using eye gaze? Are they using eye gaze to try to get your attention, to show you something, or do you never see that? So that might be something that would raise a flag, like that's a difference in those nonverbals. Decreased gesture use. You're probably familiar with the 16 gestures by 16 months. Are we seeing these kids, but blow kisses, raise their arms up for being picked up? Are they waving? Are they pointing? Are they doing a shrug for, I don't know, are they using a hand to push away? Do you see that? Or are you noticing that they really aren't using those gestures? And in addition, are they not understanding it when you are? If you're giving them a come on gesture or a shh gesture, are they understanding that? Or do you need to give them lots of support? Again, is there a quality difference in how that's being done? Are they not showing items of interest? Think about young children. If they have a toy that they think is really cool, they're going to come up to you and show you, like, look at this. But if you, again, don't notice that happening, the quantity and quality of that is different. If when you're showing an item, they're not looking at it. If you're trying to point to an item of interest, like, look at that airplane in the sky, are they able to do that? Or does it look a little bit different? You may see childhood apraxia of speech. We do know that about 25% of children or autistic children will remain non-speaking throughout their entire lives. And then perhaps it is because of apraxia of speech, that ideation and the motor planning of being able to get the mechanism working. You may see echolalia, or the use of gestalt. So, and this could be immediate echolalia, where they say a word right after they hear it, or it could be that they are using scripts from shows or media or songs that they know to communicate. It may come across in jargon, that you may hear a lot of They may not have necessarily true words, but maybe they're using intonation and jargon in order to communicate. Another area that you may see some differences in is play. This is actually a really big one. When we do our evaluation, we do standardized testing, but we also do a lot of unstructured play to look at this because, again, quality and quantity. What does play look like? It's not that these children don't play, but the play looks different. So it may be perhaps it's very either self-directed. I'm going to play. I know exactly how I want to play, and it's got to go this way. Or it may be very limited in its play. One example I give about this is I was working with a young girl, and we were playing dolls, and she was fine if we were covering the doll up with a blanket and taking the blanket off and putting the doll back to bed. That was her routine. She was able to do that. But the minute that I handed her a bottle and said, "Oh no, baby's hungry. Let's feed baby," she didn't know what to do with that. And then she looked at the bottle and said, "But there's nothing in the bottle." So there was lack of that imaginative play. And the pretend play was very, very limited. So you may see that, the repetitive play. There may be preoccupations, those special intense interests that we talked about, interest in those atypical items, like I told you, the bottles or the spatulas or carrying around different kinds of items. Those sensory differences, you may see hypotonia in these kids. So you may see it in their face. It may be part of the reason why speech might be difficult. Or your OT and PT may see it in their gross and fine motor skills. And then lastly, just difficulties with ideation and movement, communication, and play. So ideation is that idea. I've got something I want to do, coming up with that idea, and then being able to carry that out in some sort of motor plan, right? So you may see some difficulties, and that may be part of the reason for the repetitive play and the repetitive speech, because the ideation may be difficult. Want to move into assessment now. If everybody's okay with that, everybody good? Probably you need to move a little bit faster so we can get to some practice questions. Again, typically done by observation, ideally done by a team, because we're all looking at different things. Speech language pathologist to look at communication, OT or PT to look at those motor skills, and as OT to look at the sensory profile of a child, a psychologist to look at cognitive skills. And they were the ones who will typically do some of these more standardized tests. And then a medical provider to look at the medical history. We know again also that about 20 to 30% of children that have autism or individuals that have autism will have some sort of medical or genetic difference that helps explain some of the behaviors. And so having the medical component in there is very important. Also too, some of the behaviors that we might see that aren't part of the diagnosis, but that typically we see in kids are like difficulty with toileting, difficulty with eating. Because of those areas that they have difficulty with, they translate into those areas of daily living that become difficult for kids. And so sometimes a medical provider is able to handle some of that from a medical perspective as well as the behavioral perspective from the other people on the team. One of the things that has come about that is really nice is that we are identifying earlier autism, and our pediatricians are helping parents. They're asking questions earlier through some of those screeners that are on there. The MCHAT, the ages and stages, the first year inventory are all things that pediatricians may use in those 12, 18, 24-month visits to make sure that a child is meeting certain developmental milestones. And when they're not, then they're able to refer on for further diagnostics. The gold standard for autism assessment is the ADOS, and that stands for the Autism Diagnostic Observation Schedule. Unlike some of the tests that we give for communication, the ADOS is just this very, it's typically done by either a trained developmental pediatrician or a trained developmental psychologist or a trained SLP. It is an unstructured test. There's lots of play opportunities, and what you're looking for is how does a child deal with this back and forth social reciprocity within play environments. So there are many different subtests to the ADOS, and it changes depending on the language skills of the child, whether or not they are non-speaking, or they're using the words, or if they're using phrases, or if they're using conversational speech. There are different modules in the ADOS. It takes a while to get, but it also takes a while to learn it. But that is why it is the gold standard. It is actually done with interactions with the child, where the CARs and the GARs are more parent interview. There is some observation in those, but it's also a lot of asking parents questions, which of course definitely should be a part of a good evaluation anyway, a very good, thorough history. And then looking at those developmental areas and then doing something much more unstructured. So for instance, one of the tests on the ADOS is blowing bubbles. And then withholding. What does the child do when you withhold? How do they let you know, I want more of those? Do they use that eye gaze? Do they use that point? Do they use some sort of gesture? Do they use a word to let you know, I want more of those? What do they do when you give them a choice? What do they do for pretend play? So you maybe have a birthday party, or you give a baby a bath, and you see what can the child do. Are they showing symbolic play? Are they showing imaginative play? And you're coding all of this as you give that ADOS test. You're looking for those areas of difficulty with social reciprocity and those RRBs on the ADOS. Any questions about assessment? So let's say that you've gone through assessment. The team has gone through assessment. You have an individual, a child, or sometimes an older child, or sometimes even an adult, and you have decided, yes, this individual meets criteria for a diagnosis of autism. Then what? What do you do? Well, then you start thinking about, is intervention going to be of benefit for this individual? Is it something that the individual and the family want? And if so, what kind of intervention? And we talk about behavioral interventions, therapeutic interventions, caregiver training, medical interventions, and then any referrals that we might need to do. So some typical behavioral interventions would be things like applied behavioral analysis, or ABA therapy. Excuse me. Where you are working from a standpoint of, there's a certain kind of almost an ABC of behavior. There's an antecedent, a behavior, and a consequence. And can we work on changing either the antecedent or the consequence in order to change the behavior? There's a lot of controversy, of course, about ABA, as it has a very distinctive past. But ABA is changing a lot, and we are recognizing the importance of naturalistic and child-led interventions. And ABA is following that. And so ABA can help with a lot of the difficult behaviors that families might be experiencing, or individuals might be experiencing. They may be able to help with learning how to do some of that social reciprocity, how to work on play, how to do things like sharing. They also may be able to help with things like toileting, and being able to sit at a table and have a meal with the family. So those would be some of those kind of behavioral interventions. Therapeutic would be things like speech therapy, occupational therapy, therapy to address communication needs. So speech language pathologists, we may look again at those early language things like joint attention, which is, I'm going to look at an object, I'm going to look at you, and I'm going to look back to the object. 3 points there, that's joint attention. And you want a child to be doing that because it brings people into an interaction together. So that's joint attention. And then you want to have engagement. Engagement is, we've got this back and forth. We are both doing this thing together. We are enjoying this. Is that social reciprocity? Can they do that with and without language? Can they do that with gestures? So the speech language pathologist would work on that. We would work on trying to increase expressive and receptive language. We could work on trying to help improve play skills. We may be working on helping to improve motor speech skills for an individual with autism. We may also be looking at augmentative and alternative communication. even if a child does grow and become a verbal speaker, that may be quite delayed. And we do know that behavior and communication go hand in hand, right? So we could be a big part of that. Your occupational therapist might be looking at sensory profile. How can we help this child be able to regulate and feel good and be ready to learn, be ready to focus, as well as working on some of those motor skills. Another really important component of autism intervention is this caregiver training. Therapy is only for a part of the time. How can we help caregivers be with a child who is maybe learning differently? I mean, it may be that they're learning language differently, or that they're learning how to play differently, and they maybe have these different sensory needs. So how can we help a caregiver understand that and meet their child where they're at and help them learn in the way that most makes sense for their child? And I've talked a little bit already about medical interventions that may be a part of the intervention. And then any referrals that maybe need to go on that people are noticing from that, whether it be audiology, physical therapy, perhaps other medical interventions. So this leads us to some of the practice questions, unless you all have questions that you would like to address from any of that, or anything that maybe is confusing to you, or anything that you're wondering, are these the kinds of things that might show up on this? What do I need to understand about autism as I begin my career as a speech language pathologist? No? Okay. So the first question that might be like something that would show up on the Praxis is, which of the following is not one of the primary symptoms of ASD? So you can either put it in the chat or call it out. We're a small group, and call it out. This one's fairly easy, even if you're just looking at the vocabulary used in the question. And this one came from the Therapy Ed book. It's one of their practice tests. So, we've got some. Yeah, thank you for the participation. Yeah, it is C. It is C. So one of the ways that you can kind of look at that is look at the vocabulary of those first of A. A talks about impaired development of reciprocal social interaction. So B is atypical behavioral patterns and interactions with objects. D talks about deficits in social communication, where C talks about typical attention span. So that one is not necessarily one of the primary symptoms. We are looking for things that are, when we're talking about those behavioral characteristics and looking for how we're going to diagnose, we are looking for things that are different, things that are appearing different from what we would typically expect. So A, B, and D give you an idea. Yeah, those are things that are different, where C is like, no, this is what we would expect for a child. So the answer for number 1 is C. Question number 2, ASD, which is autism spectrum disorder, is described using different severity levels. Which severity level requires substantial support, such as marked deficits in verbal and nonverbal social interaction? Well, right away, how many different levels are there? Anyone? Oops, I'm sorry. There's only 3 levels, so you know that D is not correct, right? And we talked about how level 1 is kind of minimal, level 2 is marked, and level 3 is severe, significant. And so that lets you know that the answer to this one is B. The way that you can tell the difference between that substantial support is the idea of it as severe versus marked deficits. So level 3 would be severe deficits. Question 3, which of the following is an example of reciprocal social deficit? Poor conversational turn taking, repetition of utterances spoken by others, hand flapping, obsessive preoccupation with cars. Now, these are all things that you may see in an autistic individual, right? but which one is about that reciprocity, that back and forth, back and forth, back and forth? Anybody want to hazard to take a guess? So understanding that that social reciprocity, reciprocal, meaning it has to be between two people, should lead you to answer A, for conversational turn taking. It has to be I do something, you do something, I do something, you do something. It's those circles of communication that we talk about, that back and forth. The other ones may be things that you see, but they're not necessarily about the reciprocal part of a conversation or of an interaction or of a relationship. Question 4. Everybody doing okay? Are these making sense for you? And give me a thumbs, like a thumbs up if it's good, or thumbs down if you want to go back over something. Good. Okay. All right. So which of the following is the leading theory regarding the etiology of autism? And this is kind of a hot topic right now. But one thing I want you to keep in mind when you're taking the Praxis is all of the things that you're hearing right now in the world of autism about etiology, about interventions, about medications for interventions are all kind of new avenues that we're thinking about and that we're exploring. And those aren't going to show up on the Praxis this year. So remember that. And think about what makes up evidence-based practice. And one of those is that you want to have rigorous studies that take out variables, so that you can look at one variable and see whether or not that is what is happening. So keeping that in mind, what one is the leading theory that we have right now of what is the etiology of autism? Vaccinations, lack of parental environmental stimulation, genetic predisposition, or delayed language development. Well, vaccinations, there's been a lot of questions about that. But study after study has not shown that vaccinations are a cause for autism. That has been shown and replicated over many studies. Lack of parental and environmental stimulation. Well, we talked about how autism is a neurological, biochemical disorder. So it isn't about environment. It is about an internal biological environment instead. Genetic predisposition is we do know that there are certain genetic things that happen that will bring about the behaviors of autism. We can recognize that in about 25 to 30% of individuals. So that's the correct answer, C. Delayed language development is not the etiology of autism. It might be something that you see in it. It is not necessary that you see it in autism. And delayed language development on its own is not anything that would lead us to necessarily say this is autism without the other components of social communication and RRBs. Which of the following are warning signs of autism in young children? Difficulty with pronouncing their name, and difficulty with following directions, noticeable gross motor delays, and they're not yet potty trained, a lack of response to name and repetitive body movements, or they're unable to understand first then phrases and have poor concept development. So we are currently diagnosing kids as young as about 18 months fairly regularly. So one of the things that you have to keep in mind is, again, quality and quantity, quality especially, but also looking at developmental milestones. We don't want to be we don't want to be not giving a child credit for something that maybe developmentally they're not even ready for, right? So something like being able to understand first then phrases might not be something that we would expect a young child to have the ability, even a young child who is neurotypically developing, to be able to do. So that one is taken out. D is taken out. Difficulty pronouncing their name, difficulty with following directions. That again is more about speech and some higher level language, so it's not that one. Gross motor delays and not yet potty trained. Typically we don't always see gross motor delays. That wasn't part of our criteria, right? And potty training was not a part of our criteria. But the lack of response to name, that's that social reciprocity. If I call out, hey, Johnny, and Johnny doesn't look, and I call out, hey, Johnny, hey, Johnny, hey, Johnny, and he consistently ignores me, and he has those repetitive body movements, those would be signs that we would want to say perhaps we need to do further evaluation for autism. So the answer to number 5 is C. Number 6, which therapy method focuses on spontaneous, interactive, pleasurable activity with a child? Tonight, we haven't talked much about the different types of therapy that are out there. Applied behavioral analysis, we'll talk really quickly, is again that antecedent behavior consequence. It's kind of working on changing those antecedents and those consequences in order to change that behavior, the B. So sometimes those can also be pretty structured. That is not having spontaneous, interactive, pleasurable activities is not a part of ABAs necessarily. So it would not be A. Augmentative and alternative communication. You might hopefully you're using spontaneous and interactive, pleasurable activities, but that is not necessarily the focus of that intervention. Floor time, though, is based on spontaneous, interactive, pleasurable activity with a child. It's about coming into the child's natural environment, following the child's lead, meeting them where they are developmentally, and trying to build on that interaction within a very naturalistic, interactive, pleasurable environment. So that would be the answer for 6, would be C. Social stories would be one another tool that we might use in order to help a child understand. So social stories, again, are those books or video modeling or short stories to help a child with new activities. Number 7. Oh, yes. Yeah, you got it. It is B. For number 8, which of the, oh, did we do? Sorry. Number 8, which of the following assessments might a parent and a pediatrician fill out? So that's going to be A, that first year inventory. That's one of the things that pediatricians do. You'll notice that the other 3 are tests that a speech language pathologist would complete, and not necessarily for autism. Number 9, which of the following defines a criterion referencing? And again, these are questions that came from the therapy ed, some of their questions. So you may find things like this. So criterion referencing is this idea that if a person has a certain ability, and does their performance match their ability? And so if there's a discrepancy between those, then that cues us into this person maybe would benefit from intervention to help them get up to their potential, to get up to their ability. So keeping that in mind, the correct answer for number 9 would be a discrepancy between cognitive ability and language performance. If you have a child who has a cognitive score of average, but their language skills are below average, then that's that discrepancy. So comparing a child to criterion referencing is comparing the child's performance to a set of standard skills instead of comparing them to their peers, which is what most standardized tests do. So you want to take a peek at those. Again, another reason that you want to have an interdisciplinary team. Correct response is B, yes. And the last question I have for you, which of the following is an example of working on theory of mind? So theory of mind is something that's been around in the world of autism for a while as something that maybe kids have difficulty with. And it goes back to that social reciprocity, or that sometimes the difficulty with nonverbals and those difficulty with maintaining relationships, that whole social communication part. Can they understand things from another person's perspective? So which one would it be with this one? Since theory of mind is all about recognizing something in another person, so it would be about the correct answer would be B. So teaching them to recognize emotions in their classmates. So theory of mind is being able to see things from another person's perspective. If your classmate is upset, if they are happy, if they are excited, can you understand why? There is something that we use sometimes in our assessments called slam cards, and there is one where it's a story of a kid who brings a bunny to school, and the bunny gets loose in the classroom, and there's a picture that shows some kids are laughing, some kids are crying, some kids are on their desk kind of hiding, and some kids are just ambivalent. And you ask the student, like, why are these kids sad? Why are these kids scared? Can they understand why somebody would be scared? A lot of times the typical response that I get is, well, I like bunnies. I would be happy. So they can talk about their own experience, but they have a difficulty using theory of mind to understand why some of the students in the picture are afraid. And so that would be teaching them to recognize emotions in their classmates. What is somebody else's experience? What experience are they having? And how can you read that? Does that make sense? I hope so. Okay. I have some case histories, but they would we can talk a little bit about if you want to share uh some time and some of your thoughts. So Finn is a 2-year, 4-month-old. His parents have scheduled an evaluation with an interdisciplinary team due to concerns with his overall development. He is non-speaking, prefers self-directed activities, and demonstrates a variety of sensory characteristics. So and as you're approaching those questions on the Praxis, I want you to kind of be thinking about that, thinking of like this whole picture of autism, like who is going to be involved in this? What are some of the areas that we're going to be looking at if we're concerned about autism? And because of those areas, what then would we recommend for this? So do you feel comfortable sharing what you might think, like what would be some of these areas that you would want to make sure that you're addressing for a young kid whose parents are concerned about autism? It's all right if you don't want to, we can talk a little bit about it. But again, going back and always thinking of those areas of social communication, that pragmatic part of language. How am I going to use what skills I have for communication, whether it be words or whether it be gestures, or whether it be behavior. We see that a lot in autism. If I've got no words, maybe what I need to do is throw a tantrum on the floor, because that lets you know that that is not what I wanted. So all of those are forms of communication. So we want to be looking at, how is this child communicating? How are they playing? What is their sensory profile? How are they interacting with other people, with family? How are they interacting with peers? What are their interests like? What does their play look like? So these are the kind of areas that we want to, and remember, we're looking for differences. So I'm sure in the course of your studies, you've talked about differences, delays, and disorders. So sometimes there are delays where a child just looks like a younger child. And then sometimes there's something that goes very, very different. And so then we're talking about disorder at that point. And that's where autism fits, where things just don't look exactly like you would expect. This didn't happen exactly like I expected in all those areas of development. So the kinds of recommendations that we might make for a kid like this are those behavioral and therapeutic and medical and caregiver training, those kinds of therapies and programs that may help the family be able to help this child continue on their path in their development. What if we have somebody who's a little bit older and they're going to be starting school? How would testing be different? And are there any areas that we maybe want to look at now that we weren't necessarily looking at for that 2-year-old? So testing might be different because maybe we have more language at this point, or maybe we have more skills at this point. We want to be thinking also about cognitive skills in a little bit of a different point. It's around the age of 5 or 6 that kids go from, yes, they have some delays potentially in cognitive skills to, is this an intellectual disability as well? Sometimes that you will see that in autistic individuals. You may see an intellectual disability as a comorbidity or as another diagnosis. So you want to be thinking about that. And then how does that impact Sally's learning within a classroom environment as she's going to be starting school potentially? What kind of accommodations would she need? Do we need to maybe talk with educational team about what can we do to help support Sally as she starts school? We also might be looking more at some of that social communication that might be a little bit easier. Those slam cards that I was just telling you a little bit about, being able to do some of those peer interactions more might be a part of testing as well. And then the last case history I have is about, what about when we have an autistic young man and an autistic adult who is leaving the school system and heading out into the community? Even with a diagnosis of ASD level 1, what are some of the things that we want to consider as this individual transitions from a school environment where they've been for years into either a college environment or a community environment, perhaps a job? What are some of the supports that this individual may need? So thinking again, they're level one, but it's new environment. So those levels might change. Going from a high school environment into a college environment might be very different and might all of a sudden change. How is this person be able to interact socially? So you may want to work on some of those kinds of social skills of what might be different. How can you let people, how can you make friendships? How might those friendships change when you're having to make new ones? So you might be working on some of that. And there might be other ways to help with regulation or being able to handle the workload or the new demands that come with transitioning into a new environment. How will you best communicate those? How will you make sure that mental health is okay? As we see a lot of times in autistic individuals, we sometimes see higher incidences of some mental health issues. So we want to make sure that those areas are being addressed so that this individual can be as successful and independent as possible. That is actually all that I have for this evening. Are there any questions? I want to just remind you, as Dr. Higdon said, if you do think of any questions, please feel free to reach out either to her or to myself. I can put my email in the chat as well.
Thank you, Gina. And let's see. Danielle has a question. Would it be possible to access or rewatch the presentation from the beginning? So we record the office hours, and sometime in the next 24 to 48 hours, the recording will be posted along with Gina's original content video that was posted this past week. So you probably arrived after I explained, but we're taking a different direction this year. We're going to post the content lectures a week before each one occurs, and then we're going to record the office hours and post it side by side with that. So you'll be able to get the content, go back over the information that Gina presented tonight and the question and answers. Now, in addition to that, I referred people that were on at the beginning to to purchase the app at the therapy website and the book, of course, and do the practice examinations. In addition to that, since you attended tonight, if you have more questions once you get into your study group or you're studying for the Praxis and you want to contact either myself or Gina, Gina's put her email address in the chat, and I'm getting ready to put mine in. So you have access to us because you've attended this evening. So you can reach back out to us. It can be 2 months from now if you want to, but I will keep a running list of people who have attended. So you maybe pass that on to some of your friends that are preparing for the Praxis too. The Praxis also, not the Praxis too. But we're hoping that people will look at this as a total package. The book, the app, the content video, the office hours video, and then reaching out to us if you need more help. Long explanation to your question, but that's where we are. Thank you, Ms. Keene, so much.
Thank you.
And next week's topic, I believe, is speech science. So we'll see. We'll start preparing that material for next week. Gina, do you want to stay on for a minute
Sure, I
after the
will.
students jump off?
Thank you
Okay.
very much.
Mhm. There. Okay.
Are we still recording?
Yes, we are.